Hi, everyone. Welcome. We're going to give it just a minute to let people join. So glad to have you with us. Thank you all for being here. Our numbers are still ticking up, so we're going to give it just a minute. All right. Hi, everyone. Welcome. Think we have a bit of a quorum here, so thank you all for joining us today. Welcome. My name is Katie League. I am the Behavioral Health Manager at the National Healthcare for the Homeless Council. I am based in Baltimore, Maryland, and I am thrilled to bring to you today with my colleague, Kate Gleason-Bachman, our webinar entitled Buprenorphine in Primary Care, Treatment, Support, and Overdose Prevention. We are thrilled to have an incredible panel today to talk about their programs. We have 3 different programs spanning across the country with us, Boston Healthcare for the Homeless, 4th Street Clinic in Utah, and Houston Healthcare for the Homeless in Houston, Texas. We are so thrilled to have our panelists here. You'll hear from them shortly, but we welcome you all today. A little bit of housekeeping. As you have heard, this is being recorded. We do have both a chat and a Q&A feature. I am not always great at knowing which one to use. So the chat is like the welcome, hi. You should hopefully be able to communicate with everyone. If you look at that 2 drop-down button, you should be able to select everyone. Feel free to utilize that. It is also a way to ask questions. We do have a Q&A feature. We will check that as well when we get to the Q&A section. So that is also a way if you would like to submit a question to the panel. When we get to that point, it is another way to do it. We will do our best to monitor both, and we are really delighted to have you all with us. As I said, I am from the National Healthcare for the Homeless Council. We welcome you all today. The council has been around since 1986, and we are very fortunate to be the member organization for Healthcare for the Homeless programs, respite programs, housing and social service organizations across the country. We have the great privilege of working with the amazing Healthcare for the Homeless projects that exists in all across the country, in every state, and learn from and lift up the expertise and the experiences and the incredible skills and innovation that are happening in your communities. So that is our privilege. As I said, kind of a little of agenda today, just so you know what it's going to be a fast hour. We're going to do a very basic overview of treatment options for opioid use, just to get us level set. Kate Gleason-Bachman will take charge of that. Then you're going to hear from the 3 model programs who have really different and wonderful experience working within their respective communities. You're going to learn a little bit about their communities, hear from them, and then we'll delve deeper as we go into the panel discussion. So hopefully you're going to walk away with with some real concrete ideas on either how to implement, to modify, or to expand buprenorphine access within your communities, to look at how you can decrease barriers to accessing for care for substance use and in general. So hopefully you'll be able to think of ways in which this is really applicable within your community. And as I said, you're going to hear from our incredible panelists from our 3 programs. I will allow them to introduce themselves when they start about their program. So first, I am going to hand it over to Kate Gleason-Bachman, and so that she can kind of do some level setting for us. Kate?
Hi, everybody. Thank you so much. Thanks, Katie. Thanks to all of you for being here. As Katie said, I'm Kate Gleason-Bachman. I'm the Senior Nurse Manager at the National Healthcare for the Homeless Council, and I'm based in Philadelphia. So what I'm going to do is just a very quick kind of intro level setting on buprenorphine, which is our focus today in terms of medications for opioid use disorder, and then we'll hear a little bit from our panelists. So just to think a little bit about kind of what buprenorphine is, and I know a lot of people may be familiar with this, but we just want to make sure everyone's on the same page before we dive into talking about more of the programmatic things. So buprenorphine, which is sometimes called by its brand name, Suboxone, is a medication that's used to treat opioid use disorder. Buprenorphine is what is called a partial agonist. That means it's a medication that works through partial activity on opioid receptors. And what that kind of looks like for a person taking it is the medication helps prevent withdrawal, it decreases cravings, and does so without some of the other more typical effects of opioids that are considered full agonists or working completely on opioid receptors, like sedation and euphoria. Buprenorphine is taken one of two ways. It's either dissolved under the tongue as a tablet or a film 1 to 3 times a day, or it can be given as a weekly or monthly long-acting injection. Buprenorphine, very importantly, can be prescribed in primary care settings by any provider who can prescribe controlled substances. Um, Buprenorphine is a safe medication, also very importantly, with a low risk of misuse and a low risk of overdose. Um, the vast majority of buprenorphine that is sold on the street as a result of diversion from people who have gotten a prescription and are selling it is used to manage withdrawal or for efforts towards recovery. So it is not misused. Next slide, please. So thinking about buprenorphine and overdose, having access to buprenorphine is a vital component of opioid treatment and overdose prevention in the United States. So in 2021, from a few years ago, only 1 in 5 people with opioid use disorder were receiving or received treatment with medications for their opioid use disorder. Because buprenorphine can be prescribed in primary care, it is a very important component in expanding treatment access, especially in places that might have limited availability of other treatment options like inpatient facilities or other outpatient care. Primary care may be one of the only places people can access treatment services, so having buprenorphine available is quite important. Traditionally and historically, since buprenorphine has been available, healthcare for the homeless settings have led the way in buprenorphine prescribing across the U.S., often providing a disproportionate number of prescriptions compared to the population that we serve, being very innovative in how we deliver those programs, how we allow people access to care, which we're going to hear more about from our programs. And so in that way, healthcare for the homeless settings have really been and offer now a model for how to integrate buprenorphine into primary care and expand services. The final thing I'll add is just very importantly that taking buprenorphine decreases overall overdose risk for opioid overdose, even for people who continue to use opioids after starting or along with their treatment. So it's a really important component of overdose prevention for people who are using it, even if they are continuing to use intermittently or continuing to use as with their treatment. So with that, I am going to turn it over for our next slide. To Chris, who is going to talk about 4th Street Clinic in Salt Lake City. So thank you so much. Thanks, Chris.
Hi, nice to meet everybody. My name is Chris Smith. I'm a psychiatric nurse practitioner at the 4th Street Clinic, which focuses on unhoused individuals or uninsured individuals, mostly in Salt Lake County. I've been here 9 years, and we piloted our buprenorphine program at the beginning of 2021 with me. So this is a primary care clinic with integrated behavioral health. We have an on-site pharmacy. We have a dental clinic. We have an RV that is a mobile clinic. It goes to different shelters and other sites, and we have a street outreach team. And we're able to get a lot of volunteer clinics like neurology and ortho and stuff. As it says here, most of our patients have Medicaid or uninsured. Most of them are experiencing homelessness, at least when they first come to us. Next slide. So when we decided to try to start a program. We were looking at community partners that were already offering services and trying to fill a gap for people who we figured that people who can make it to their clinic every day or every week and keep a place or keep a job, and they were already doing that, and so we were going to be trying to engage people who miss a lot of appointments, and we designed our program around that. For new patients, we ask people to walk in to establish, and you can establish now with any, you can establish with primary care and get buprenorphine. You can get buprenorphine through behavioral health providers. We do a little telehealth. It's usually is just difficult for our population, but it is available. You can have appointments once you are an established patient. We decided that missed appointments would not result in exit from the program. You can always walk back in. We take a home induction approach, which I think we'll expand on later. We do individual appointments. We looked at group options and didn't feel like we could pull that off here. We have therapists on site who can engage with patients, and then follow-up intervals can be, often a week after the first visit, but very individualized. Next slide. In 2021, in January, when we piloted the program, it was, I'd say 95+% of the patients, it was going to be BH prescribers only. That was mostly with me, with the LCSW, who helped us get the program off the ground. So when you look at that 2021 unique patient count, that's basically just all people I saw and all prescriptions I wrote. And then about halfway through the next year, we expanded it to all the prescribers, and we've really grown it a lot. And I now save my time for referrals from primary care for cases that feel tough to them because the person has comorbid psychiatric issues that are getting in the way, or more complicated substance use issues. Next slide. That's it.
Thank you so much, Chris. So we'll have Paddy come on and tell us a little bit about the program and healthcare for the homeless in Houston.
Hello, everyone. My name is Paddy Meda. I'm a physician assistant here at Healthcare for the Homeless Houston. We are the community's only federally qualified health center exclusively providing care for individuals affected by homelessness. A quick overview of the programs that we offer. We are a primary healthcare clinic. We offer specialty care such as ophthalmology, pediatric medicine, women's health, podiatry. We have an integrated mental health program with behavioral health services. We have our medications for opiate use disorder program, a robust case management coordination service, along with social services here. Offer transportation services via Project Access, which I'll talk about a little bit more later. We offer clinical education programs and also our robust street medicine program. Next slide, please. We serve patients here in the city of Houston, Texas. Just looking at the umbrella of our patient insurance status, majority of our patients are uninsured, 69%. 18% have either Medicaid, CHIP, or other public coverage. And then also about 7% with private coverage and 6% with Medicare. Next slide, please. Now, specifically our buprenorphine program, we obtained quite a few referrals from internal providers as well as external partners, hospital systems, and also self-referrals. The initial visit could either be by appointment or walk-in opportunities. The follow-up visits via telehealth, that is an option. However, it's really patient-specific based on the needs and the barriers of the patients. As far as the induction approach, we have both the out-of-office and in-office induction approach available, but the out-of-office or at-home induction being the most common. Next slide. As far as appointments and follow-up intervals, the follow-up appointments after induction could be daily to weekly for newly established patients, and the duration between the visits can be extended anywhere from 2 to 4 weeks based upon clinical stabilization of the patient. Now the staffing structure is quite unique in that we value the integrated model, which includes the medical providers, the licensed chemical dependency counselors, the behavioral health consultants, as well as various resources for our patients, which include therapy services as well, to ensure both medical and the psychosocial needs are addressed for our patients. Clients also have the resource of case management support to help with housing, benefits, and other non-medical drivers of health, essentially to create a full continuum of care that promotes recovery and stability. Next slide, please. Now, participant data, the age ranging from 25 years old to 64, and just looking at the umbrella of our program here, we have 88 unduplicated patients, about 71% without any insurance, 29% with Medicaid, CHIP, or other public coverage, 52% identify as female, 48% as male, and about 38% disclose the race, 38% being white or Caucasian, and then 24% being Black or African American. We also have our Be Well program, which is an excellent partnership. I'll talk a little bit more about that later on in the discussion. We have about 14 participants, and all 14 do not have any insurance coverage. Next slide. All right, thank you so much.
Thank you, Patty. And now we're going to hand it over to Mish and Jackie from Boston Healthcare for the Homeless.
Hi there. I'm Mish. It's short for Michelle Whitaker, and with me is Jackie. And we're going to talk a little bit about two very specific programs within Boston Healthcare for the Homeless program. First off, I want to talk a little bit about SPOT, which stands for the Supportive Place for Observation and Treatment. Our Healthcare for the Homeless program is quite large, and we have a main building here. We also have a lot of smaller clinics embedded in shelters and at 2 different hospitals throughout the city. And we have an outreach van, we have a dental clinic, we offer primary care, behavioral health. But something that was really missing from our program in 2016, when the opioid overdose epidemic began to really hit Boston hard, and particularly staff in this building started noticing more and more that they were responding to overdoses on their way to work, on their way to their car after work, and even in our bathrooms inside the building. And so in response to that, BHCHP opened in a former conference room what we refer to as SPOT. And SPOT is essentially a sedation monitoring space. So it's not unlike a overdose prevention center, except that participants are not allowed to actively consume substances inside. But if they have consumed substances, or they have a friend or a peer who has consumed substances that are sedating in nature, and they're concerned about their friend's well-being, they can bring them to SPOT. We have 6 chairs and 6 vital signs machines, and our staffing model is 1 clinician who is typically an RN, although in the afternoons, we have an EMT who comes in and gives the nurse a lunch break, and then comes back and helps out for the remainder of the day, and 1 case manager. We also have a nurse practitioner or a doctor who's available kind of on call. They'll usually be somewhere in this building or next door in one of those satellite clinics I had mentioned earlier, doing primary care and urgent care kind of walk-in visits, but they're available to come respond to not just an emergency in SPOT, but anything from a wound that might look infected, or somebody who might need a provider evaluation for a referral for a higher level of care. But I also want to talk about what happens when our patients are ready to take kind of another step along this spectrum of substance use disorder care. Yeah. Take it away, Jackie.
Yeah, so I'm Jackie. I'm the nurse manager for the OBAT team, but OBAT is an acronym that's really popularized in Massachusetts, but I'll unpack it real quick because this is national. It's office-based addiction treatment, and it uses a nurse-centered model. So it's basically nurse care managers that are managing this chronic illness, like we have in the past, like looking at diabetes, or back before we had better options for anticoagulation, like anticoag nurse. So I am also embedded in the mothership, the bigger building, but even though we don't have OBAT nurses at every little satellite clinic, we do offer access to buprenorphine basically out of every satellite clinic. We even have one embedded in transition TSS. So, and we have a provider there that can either bridge patients that come in that are a little disconnected from the buprenorphine provider, or somebody who's, you know, really part of the community and needs primary care too. They can get them started and have them come over to us. Our access to buprenorphine is typically on demand. So walk-ins, you come in the door, you're looking for primary care, or you already have primary care with us, you are going to be seen by a provider today for your buprenorphine treatment. It's really, really important. Even if the person needs to micro-induct, and I can talk about that later on in the discussion, we want to have a plan. We want to start treatment, even if it's, you know, preparing somebody for treatment. Because I want to encourage people to think about buprenorphine treatment, not just as a light switch, like, oh, you're stable enough, you're going to take this, your use will be minimal. I want to think of people to think about controlling withdrawals as well, especially with your long-acting injectables such as your Brixadi and your Sublocade, because if you're controlling withdrawals, even with somebody using on top, they are engaging way more in their appointments. They are, even though people are, you know, either intoxicated or in withdrawal, trying to, you know, find some kind of equilibrium or just not feel worse, they care about their health. So if you're controlling that, you take that out of the equation, it's not like a magic cure. It does open a lot of doors for people. And, you know, respecting the continuation of use, you can move to any end or be in the middle. It's not a static state of being, and it's not a linear path. So, so I alluded to, we provide the long acting. We are going through some insurance barriers that we can use. So we can use Brixadi weekly injectables to do rapid titrations up. But we do, we have that available on monthly formulary. Same thing with the both doses of Sublocade. Our team structure, when we're looking at the main program, the OBAT program, we have team of nurses. We're overseen by a medical director, and we're embedded in primary care. So if we need somebody to be evaluated to start, or we have, you know, a clinical question that's outside of protocol or our scope of care, we have plenty of providers that we can pull in. Adjacent to that, and I would love to have a discussion at a later date about the other services we provide. We also provide START treatment for stimulant use disorder that uses a contingency management model. And then we also provide access to quick referral to methadone maintenance treatment via Title 21 for our primary care patients. We're very fortunate to be across the street from BMC. So we work with them quite a bit, supporting our patients and, you know, trying to enhance, you know, any kind of safety measures that they can employ.
Yeah. Thanks, Jacky.
Yeah,
and
thank you.
BMC is our the nearest hospital, so it's Boston Medical Center, and some of our providers are actually affiliated there, which makes it even easier. But so inside Spot, we aren't giving any buprenorphine or doing any of that, but we are so lucky to be in the same building as the OBAT team.
Yeah, we have a nurse that works for both departments too. That's
awesome.
Really great. We started that last July, and it's really helped because the old school thought was like, if you need Spot, you don't need OBAT, or, you know, OBAT's not allowed in there and vice versa.
Yeah.
There's really a Venn diagram of overlap. So it's really great to have that type of integration. Well, on the OBAT side, we also have therapists too, to help people with, you know, the behavioral changes and support in that capacity.
Next slide. There are no more slides.
There are no more slides. Oh, there's a slide.
Now we get to the good stuff. Yes, we are. I am going to take this down so everybody is seeing all of our focus on all of our faces, because we are going to get into our panel discussion. First of all, thank you all so much. And we hope you as attendees found that useful as just kind of level setting, because now we're going to delve into deeper into these programs, but we wanted you all to have kind of a basis where each person is coming from and how this sits within their larger health system, both within their health centers, but also kind of in their community at large. So to that, I'm going to start with you, Chris. What have you learned along the way that you wish you knew when you were first starting off? I know you shared with us that you were part of the team that started the program in at the 4th Street Clinic. So what do you wish you knew that you knew back in 2021 when you started this?
I had to unlearn a lot of just the kind of subconscious assumptions that I think a lot of people might absorb growing up about people who use drugs. And I wish I to have more quickly wrapped my head around buprenorphine as simply a medication for a condition. You have to take it seriously like other medications. When I started, there was still an X waiver. It had kind of made buprenorphine this untouchable, rarefied boogeyman of a medication that required special training, and to just come back around to this is a medication for a condition, and then let it go, that would have allowed us to get certain things off the ground, I think, a little easier.
How about you, Patty? I'm going to pose the same question to you. What do you wish that what does your organization wish that you knew that if you just knew it right from the beginning?
I honestly believe as a team, we've come to understand the importance of just workflow development, right? Not just development, but integration and implementation, and understanding that every patient story is so unique and different. And how do we create this workflow to cater to that story, to cater to those experiences, and to provide support in this journey, right? So maybe identifying and engaging potential patients, starting the conversation there, or understanding the patient's readiness for treatment, being able to monitor patients, their progress, and seeing it as progress, right? To be able to provide long-term support for recovery, and understanding that recovery is not linear, right? It's the idea of providing social support in every aspect of recovery, in every stage of recovery, and understanding the value of integrated wraparound care, where most barriers were more social versus pharmacologic. And so that's been a unique, I think, learning opportunity for every single person on staff, regardless of how they encounter the patient. And that's been a unique experience, just to have such unique opportunities to encounter patients in such different capacities, but also have that as the blueprint in adjusting the workflow to our patient stories.
Mish and Jackie, any things you wish you knew at the beginning?
When I started working in SPOT, I didn't know anything about the world of substance use disorder. I had worked for Healthcare for the Homeless program here in Boston for, at that point, about 13 years in an inpatient capacity in our respite. I was new to the outpatient clinic world. So as far as treatment options, I didn't know about Suboxone. I didn't know a ton about what is the experience of one of our patients when I see in their chart, oh, they're on methadone, they go to a methadone clinic. Like, what does that mean for them? Like, how is that? And it has just been really an honor to work alongside the people who come to SPOT and to learn from them what it does mean to be getting outpatient-based treatment for their substance use disorder.
Yeah, and for me, because I've been in this game for 12 years almost. I've worked at a different Healthcare for the Homeless in Worcester, formerly known as Hope, and I worked for the detox first. And when I came there, I did come with some preconceived notions about the use of medications as treatment for addiction. I had my own biases, but once I got into primary care nursing, I wasn't OBAT yet. I really saw the value. It really changed my thinking of like, this is another chronic disease that has some kind of, defect of an organ that needs medication, and that medication should be offered open-endedly. So I wish I wasn't so judgy in the beginning, and I wish when I was in the beginning of OBAT, I was more vocal about discontinuing people because they weren't perfect, because the old practice was if somebody was still using another substance like cocaine, then they would be tapered off of buprenorphine, which is not something that should be supported. But those are kind of my two nuggets that I wish I came into this already knowing.
Thank you all. I'm just going to move on to our next question, but I also want to encourage folks, if you have a question, you can put it in the Q&A. We have some questions that we are going to go through, but we also are happy to draw from the Q&A if folks have questions that come up. So Katie and I are paying attention to that. So the next question I have, and I guess Paddy, if it's okay, we'll start with you for this one, is just to share any strategies you have for kind of balancing substance use treatment with other primary care needs within your setting, either through, the different patient populations who are accessing care, or an individual person who's coming in both for substance use treatment and for primary care.
Sure. Truly, as I mentioned earlier, it's the idea of understanding the multidisciplinary team as the cornerstone. So here in Houston, we have prescribers, which can be physicians, physician assistants, nurse practitioners, psychiatric nurse practitioners. We also have counselors, peer recovery specialists, case managers. So we have this multidisciplinary team, which helps address all of the needs for the patients, right? And it's through a process, through a journey. And it's kind of identifying the barriers that the patients may be encountering and trying to find solutions to circumnavigate those barriers, and incorporating behavioral health into this model where the behavioral health clinicians are able to provide on-site or telehealth counseling, relapse prevention in coordination with the medical visits, right? So the idea of seeing substance use treatment as a primary care component has been really helpful in screening, addressing any comorbid conditions that the patients may be encountering, and also incorporating routine screenings with intake visits and also maintenance visits. That's been really helpful. One of the tools I feel like I find really helpful myself is scheduling regular interdisciplinary team meetings to discuss patients on a panel for our substance use program. So I encounter patients in a very different capacity compared to our LCDC, compared to our chaplain, compared to our case manager. So the idea of sitting at a round table as a team and sharing these encounters that we've had with patients is just helpful in kind of completing the entire patient story and understanding what the patient's needs are and how we can better support them. And also scheduling the multidisciplinary team care appointments concurrently with their primary care appointments, their psychiatry appointments, just to provide whole person care. That's been very helpful.
Thank you. How about Mish and Jacky? Anything that you want to add about balancing and kind of supporting primary care and substance use needs?
Yeah, so I think it's a really great thing to have this embedded within primary care, because of people will come in to see OBAT way more consistently. And that's where we can bring that in, and having the nurse care manager model, we're looking at comorbidities too. So, a lot of times somebody will come in and I'm talking to them, doing their Suboxone. Through my assessment, I find either other acute needs or chronic disease that's adjacent to it that need better management. So I can help with that, tag in the general primary care nurses if appropriate. And then also, because we have therapists too, we have open access to the therapist. I can call on one in the moment of crisis, but also we have them embedded in our program. So we do integrative rounds on people. So it's really, really nice. And if people really, again, it's sometimes people have to take baby steps in, and they might take steps back. we always just really try to impress upon the patient that they're always welcome here. They're always welcome. We don't take it as a rejection. We try to encourage them that even when you're feeling like you're at your worst, we still want to see you because of all that shame and everything. But it is really nice to be in primary care because nobody knows why you're there when you're in the waiting room too. So to reduce the stigma, that makes people more comfortable in general when they're engaging in medical care.
Thank you. And how about you, Chris? How about at 4th Street?
I think everyone touched on it pretty well. I would say that from just the clinic level, we have a really robust walk-in system. So if somebody misses an appointment, which happens a lot because people's lives are pretty unpredictable in this population, there's usually somebody to see. I really like that, and I like how that if you miss your appointment, you can come later whenever you can make it. But when we built Matt into the triage process, we initially, it ended up crowding out a lot of other reasons to walk into primary care from because we put it kind of more urgent. If you're in withdrawals, we want to be able to catch you while you're motivated, and we had to build a lot of nuance with walking in withdrawals in order to make room to kind of rebalance the scales for everything else that people walk in for.
Thank you all for that. I'm actually going to jump to the chat. A really great question from Jacob. He says, I work in a primary care clinic and coordinate buprenorphine management services for our providers. We try to be as low barrier as possible, but our providers are a little hesitant to fast track folks we meet during street outreach. We do not have an in-clinic pharmacy, so sending prescriptions to pharmacies in the community can delay care. Are there any recommendations for conducting induction in the fields? I'm not gonna call on anyone in particular because I don't know if anybody has any nuggets and or just commiseration of shared challenges in this.
Oh, I could totally commiserate about that. Our mobile clinic a few years ago, we were trying to get a waiver on our license to be able to be more flexible with the medical staff on there and have if a provider is out having nursing on there. And part of that application was how do we do inductions on the van? And it's the same barriers because there's no pharmacy on the van. Even if there's one across the street, they have to make it to the pharmacy and back. And we all know a lot can happen even if it's like a 20-foot distance. So that's super challenging. And then the other component and it's pretty true everywhere, is that risk of precipitated withdrawal too. So even if we're at the moment, the person's super motivated and they're like, yeah, I used fentanyl, I think last night. It's like, oh, okay. So we gotta do some complicated things. So I'm all ears if people have a good system to use, with all the barriers that we're looking at.
I so appreciate that. And if anyone who's out there, attendees, feel free if you've had an experience with this and something that has worked in your communities, put in the chat and we'll shout it out. This is the idea of these conversations, is to learn from one another and to recognize nobody's doing it. Nobody's meeting all the needs within their communities, or we have different barriers, or maybe the same barriers and we've found ways around them. So really appreciate kind of this group conversation around it. So I will jump back to our questions and ask, what have been ongoing challenges you have faced in your program, and how have you worked to overcome them? So I think access to medication certainly sounds like one challenge, but Jacky and Mish, any challenges that you have been facing kind of ongoing, or that a challenge that you faced and that you've been able to work to overcome in providing these services within either within your program challenges or maybe within your community?
Sorry, we're just like,
Yeah, we're like, oh, there's so many challenges.
Can we attack the thing we hate the most?
Sure.
Insurance.
Insurance
is
Yeah.
awful. It's terrible. They changed the terms. It's very confusing. And I really appreciate our benefits staff because they have a heavy lift.
They're incredible.
Yeah, so that is a huge, even in what you get as far as your buprenorphine, like, you know, some insurances are like, it has to be brand name. Others are like, no, it has to be a film. No, it has to be a tablet. Especially when you're looking at like XR bup or like extended, like your Sublocades and Brixadi, I got to know, where can I send this prescription? Some of them I can fill downstairs. Some of them I have to send out to specialty. And there is, you know, every month I have a fridge with names on boxes that they just sit because in that moment, that person was clinically stable. They were ready to go. We could have done it, but because of their stupid insurance, we had to send it out and we lost them. And I know of at least one person for sure that ended up, unfortunately, having a sentinel event from an overdose, waiting for their Sublocade to come to our clinic. So it's infuriating, to say the least.
While we have the floor, want to talk about an even closer to home challenge, which is the city of Boston's general overall response to both homelessness and substance use disorder within the homeless community, because it tends to be public substance use as opposed to privileged private substance use, which other citizens can get away with. And we have seen a large crackdown from our current mayoral administration, which has gotten increasingly more strict. Our current mayor, who ran on a platform of opening Boston's first overdose prevention center, has now announced a restriction on the number of syringes that our syringe exchange can give out per day, as if that is useful in any way. And so unfortunately, that is an ongoing challenge that we're facing, and in ways that you might not even, or as a healthcare clinician, you would anticipate, but that I think the general citizen or neighbor who might be inwardly cheering like, yay, less needles, but we all understand the downstream effects of that. And there are some that I think are even more insidious. And one of those is that we're seeing our visits in spot taper off on some days. And we can directly relate that to the days where we have an increased police presence just out on the sidewalk.
Same with OBAT too, so they can't even access their medication. They're getting placed away from the building sometimes.
Right, and so people aren't even coming in, and we know that doesn't mean that they are suddenly cured of their addiction. It means that they're not receiving the services that we're here to provide. And that's really frustrating. But one win, because you did ask for a challenge that's overcome, is that when Spot was opened in 2016, the neighborhood group that considers themselves a stakeholder, I don't consider them a stakeholder. It's not like they donate or anything. Sorry. I guess very technically from like a political standpoint, they are, because they could have totally prevented us from opening. But they asked that one of the provisions of Spot be that EMS never drop off patients to Spot. And the big fear there in their mind was that people with addiction from other cities outside of Boston would be like funneled into the city for this very unique sedation monitoring space at the time. However, despite that, I have been the manager of Spot now for 4 years, and I'm really happy to announce that just this past September, we signed a contract with the Massachusetts Controller and with Boston EMS to divert appropriate patients to Spot instead of the ER if there's no real reason for them to be taking up a spot in the ER, and they could receive the care that they need right here. And so we're really proud of that new arrangement and flow.
That's really, really exciting. How about you, Chris? Do you want to take on the question of, just to reiterate what it was, of what have been or are ongoing challenges you have faced in your program, and how have you worked to overcome them? So not you don't have to have fully overcome them. I think that Jacky and Mitch, what you shared is so important, right? Because I think we're in these they're ongoing, and they a lot of times are one step forward, two steps to the side, maybe feels like steps back, but that you're still working towards addressing them.
I think everyone's touched on this. Paddy said a lot of the issues are social, or they're circumstantial. So outside of what any given program might have as a unique barrier or asset to work with people on creative problem solving, like, are you going to make it back here in a week? Why don't I give you 2? Does your stuff get stolen? Why don't you fill every 3 days? Your stuff was stolen. Okay, we know who we can talk to do overrides or do this to access medications that on an early refill, and look at things like that. And just being aware of, just if you're going to give up the use of the substance, for a lot of our folks, you are giving up possibly the only community that you have left. And that's a big ask for people.
Paddy, any other challenges you'd like to share?
I would say something we've seen on repeat quite a bit, and it's improving, is inconsistent follow-up, right? And identifying what the barrier is. And the barrier for majority of our patients here in Houston in the past has been transportation, right? I'm not staying anywhere close to the clinic. I'm not sure where I'll be staying tomorrow, let alone a week from today. So it was the idea of our social services team to incorporate the conversation about Project Access, which is our transportation service here in Houston. It's Houston's only regularly scheduled, no charge transportation services for individuals seeking housing services. So it's a 40 passenger all ability bus, travels to 23 different agencies Monday through Friday, 52 weeks a year. So it's free of charge, great resource to kind of help circumnavigate that barrier of transportation, but also having that conversation with the patients almost every visit, right? Not just from a clinician standpoint, but from a social service standpoint, just so the patients are aware and they utilize this resource. And that's been helpful.
You've evoked one more challenge, if you're done, Paddy. I think people have touched on this too, being ashamed, and people will not come back after missing an appointment or something, and they're coming back and they're apologizing and saying, I'm so sorry. And I'm just like, if you show up, I can work with it. So just addressing that shame. I relapsed. Well, I'm glad you're here today. I relapsed for 2 days and then I stopped. Well, that's awesome. How did you stop instead of keep going? And that gets people to move towards where they're trying to get a little bit at a time.
Thank you. Yeah, thanks for bringing that up, Chris. I think we've seen in kind of historically so many programs where if someone relapses or they're using along with their treatment, services are removed rather than recognizing that as the person needing more supports, like the opposite of what they need is done. So that's wonderful to hear, people need that encouragement and support. They feel they don't need anyone else shaming them. They certainly feel, they're having a tough enough time themselves. The next question, some of you, I think, have started to address this in some ways, talking about walk-in services and talking about transportation, but are there other policies or procedures that have been put in place in your organization that have helped facilitate access to buprenorphine or that have made people's ability to access services easier? Just thinking about for other programs, thinking about this, like, are there things you've done that have made it easier for people to access care that they need? And I guess for this one, if we could start with Chris.
I think so. As I mentioned, we identified what programs were out there and realized that to engage this remainder that the initial proposal, when we looked at other programs across the country, was a lot more structured, and we looked at it, and then we just decreased a lot of the barriers, like what's the threshold for comorbid substance use and missed appointments, and requiring, I mean, for us, we tried a more of a requirement that you'd meet with the therapist, and found that was, just another barrier instead of something that we offer for 5 minutes or 30 minutes or every week. And I think this was in the printed question, was there reluctance? And there was. A program had been tried a little before I started, and it had been deemed not successful. I'm vague on the details, but so there was, I wanted to restart it for a couple years before we even got the momentum. And I think that it helped everybody who was still nervous that it was a pilot program just assigned to a couple prescribers so that they could see it move forward, see that it was a need, and also see that it was going to be okay.
Thank you. Mish and Jackie, how about you? Anything else that's been put in place that has helped facilitate people accessing services?
We look at it as like a full court press. So we have same day OBAT visits. Case management is key with that, or having some kind of like team coordinator. Because once the person checks in for open access, we start looking at their chart. We check the PMTP, and we have somebody go out there to, see what their needs are, and then also see if there's other needs there, to explain the process. So because if somebody's waiting around and doesn't know what's happening, they're gonna bolt, and so we recognize we gotta get people a plan, at least for their access immediately. Another thing we do is that if you're a brand new patient, you don't have to see your primary care provider first. You can see us first, and then we'll schedule that out. That's so key. And then also having nurse care managers, especially I always call this main clinic the mothership, because it is pretty big, is that you have nurses doing visits on the behalf of the providers. And a big thing that I saw before in my past job, and then when we had a nursing shortage for OBAT here when I first came over, was creation of wait lists, cherry picking patients, picking the people who are most likely to be successful, whatever that means. That's what happens when providers aren't supported. Even if they want to do more, they just really don't have the resources. So having a robust nursing team to conduct these visits on behalf of the provider is so key. You can see so many more people. As soon as we got full staff, waitlist gone has never came back. And I strive to make sure that happens. So there's a lot of little things that you can do. Case management can get people their PT1s if they qualify. We do have some funding for at least some T passes to get back and forth to your appointment. So a lot of little things can really together can make a huge difference.
And Paddy, how about you?
Yeah, I mean, honestly, just echoing the sentiments of the panelists here, just creating low barrier access to care. And there's just so many moving parts in doing that, but with that also so many opportunities with every single member of the team, from the front desk to triage to nursing to case management to the clinical staff, ultimately creating low barrier access to care. And honestly, that could start with scheduling, right? All the providers here have a template full of appointments, but also in that template, we have walk-in opportunities. So that's been pretty solid in providing that low barrier access to care.
Thank you so much. And I can't believe this. We are winding down, but there's a combination of two questions I'm going to ask. And after I ask this question, I am going to launch our poll. This is a HRSA funded activity. And so it is important that we get your feedback, that they hear from you to know how we did in terms of making a meaningful hour of time for you all. So my question is, or the questions, this kind of combined question, is around challenges encountering folks that might have started induction elsewhere, such as the local emergency department, that you are now seeing for follow-up. And something that might be baked into there is have you established any relationships, collaboration with first responders, fire department? I know in Boston you just shared you're going to have a diversion component. Anything else that where like the induction happens, particularly in a hospital setting or ED setting, and then this person is in front of you. So I will just open up that question since it came from the chat.
I mean, it's if the timeline adds up, or I can access, which I'm pretty lucky to be able to access a decent amount of hospital records, or I see it in Doppel, then it's quite straightforward. Even if I couldn't find any other evidence and they came in and they were positive for buprenorphine, that would tell me that they had buprenorphine in their system, and I would feel like I could roll with that.
Yeah, similar to what Chris is saying, that, you just kind of pick off where you left off in some cases. We have the fortunate, convenience of being across the street from Boston Medical Center, which includes a program called Faster Paths, where a lot of people will go through for like transfers to methadone, transfer from methadone to bup and stuff like that, that will come over to us for maintenance because they're like a short-term actor of care. But we also get patients that come in that, they started this induction process. So we got to see where they're at with it and not just assume like, oh, well, this should be day 4, so they should be at that. There might be some hiccups. They might have backed off and introduced more fentanyl because they started getting afraid of their precipitated withdrawal and things like that. So we try to gather all the information, especially if we can see the records from whatever treater started them. That's always great. Or if there's ROI, that's amazing. But a lot of times that's not the case, especially when you're dealing with people who are like, out on the street and kind of just doing whatever they can in the moment to get help or feel better. But we also have a respite unit that people can start their induction, and it's more of a medically supervised component. Mind you, we don't usually have people at respite just for these purposes, but while they're there addressing other needs, this can also be a need that's addressed within respite. And then when they're done, they can either, return or get referred out, because respite sees people not just for our patients, it's kind of a resource for the state. But if it's somebody that is appropriate for a primary care, it's just warm handoff right downstairs.
Thank you. So we have only 1 minute remaining. We do have this kind of final question of just any parting words, piece of advice that you want to give to or would give to a program that wants to start buprenorphine treatment in primary care or expand it. I'll just open it up if anybody has anything they want to add, and also say thank you to all of you for joining us today. This has been really rich and helpful, wonderful information to share, and thanks everyone for attending. So any final advice?
My one piece of advice is network and copy the homework of people who are further along than you. Use creativity, and you'll be surprised how quickly you can form a program, and don't be afraid to pilot things and try.
Yeah, and I would add, keep changing it, right? Like you're going, and then if it's something ain't working, throw it out. Look at what other people did, like they said, and also be confident in your population, that when you look at the 5 other programs, don't be afraid to add something that you didn't see, because it's going to work for your folks.
honestly, just understanding the value of a multidisciplinary team and the strength in partnerships, both at home base and also in the community.
Those are fantastic bits of advice for this type of program, for all programs. But yes, just so grateful. Michelle, Jackie, Chris, Patty, thank you so much for your brilliance today. Thank you all for being with us, for your really great, rich questions that added to this conversation. These slides and recordings will be made available. We will attempt to send them out via Zoom. If not, they will be available on the landing page for this event, which we will at least send the link to that landing page if we cannot attach the recording or include the recording and the slides as well. Thank you all for being with us. We are so grateful to our panelists, and we hope you all have a wonderful day. Take care. Be well.
Thank you. Thanks, everyone.